Welcome to Film 2 on the identification, treatment and management of diabetes in pregnancy. In this film, doctors will talk about the protocol that should be followed by medical officers and specialists for management of diabetes in pregnancy and in the postpartum period. Please watch Film 1 before you watch this film. But first, let's meet our expert trainers.
Dr. Poonam, once a patient has been referred to the medical officer with a diagnosis of GDM by the ANM, what protocol is to be followed by the medical officer regarding the further management of such a woman?
So the medical officer goes through the history again, takes it thoroughly, defines the risk factors, if any, and then redos the blood sugars again. So anything above 90 fasting sugars or postprandial more than 120, he needs to counsel the women again regarding the MNT and the exercise. The follow-up also would be conditioned according to how the sugars are and are there any other risk factors associated along with the increased blood sugars. The follow-ups happen to be 4 weekly if everything is okay till about 28 weeks, and then it can be once in a fortnight, once in 2 weeks till 32 weeks, and thereafter every week. The medical officer also checks for the HbA1c, which will tell us about the last 3 months levels of the sugars, and anything above 6.5% or the sugar levels above 200 milligrams per deciliter, the medical officer needs to refer to the tertiary care center for the specialist care.
Are there any medications that the medical officer can start if the woman lies in the middle range, that is her postprandial blood sugar is more than 120 but less than 200?
Metformin 500 twice a day can be started to, in the transient period while the patient is getting monitored before being referred to the tertiary care center.
The medical officers or the primary level healthcare workers are scared of starting women on oral hypoglycemic agents because of the fear of hypoglycemia or the sudden fall in blood sugar, as we say it. So is metformin associated with such a risk?
So metformin is like a sensitizer, exactly like how exercise is, and it would reduce the sugar levels. However, these women are going to be monitored regularly. So these are the few things which should be kept in mind, and counseling of the women should also be dependent that the frequent meals have to be there instead of the 3 meals that we all take. Important to take 6 meals, where the snacks time has to be disciplined enough for the women, in the tea time as well as at 11 o'clock in the midday time, and regular monitoring postprandial after the main meals need to be done, so that the good documentation of the sugars is available to the medical officer before referring to the tertiary center if need be.
Dr. Poonam, you have very nicely highlighted the management by the medical officer. But under what circumstances will the medical officer refer the patient higher up to a tertiary care center?
So if the medical officer notices that the patient has been non-compliant, the diabetes has been poorly controlled, and that the sugar levels are not in the normal range despite doing the MNT and the exercise, this is a time when he refers to the tertiary care center. Now, the sugar levels, the fasting, if more than 126, or the what is called as the overt diabetes, where the sugar levels either random or postprandial or any levels at any point of time of taking the sugars is more than 200 milligrams per deciliter. This is again a time when the medical officer refers to the specialist. Or if the medical officer has noticed any other risk factors, or the blood pressure becomes a problem, which is the patient is going towards preeclampsia, or the medical officer notices that the kick count or the pattern of the kicking is not right in the baby, or the fundal height is higher than normal, this equally requires referral to the tertiary care centers.
So what does the increase in fundal height represent?
So increase in fundal height is representative of the fact that perhaps the baby is growing more than normal, or there is an extra water around the baby, which is called as polyhydramnios. So these patients need to be referred for the growth scan and Dopplers to be able to ascertain polyhydramnios or macrosomia or even IUGR with polyhydramnios.
How does the management of gestational diabetes by the specialist differs from that of a medical officer?
So, if the sugar levels are consistently above the normal range, despite doing everything, then we have to start the medication. Metformin should have been started by now, which we have elucidated earlier on. With the metformin, we can also think about starting the insulin, which the endocrinologist will start if there is no response happening from the previous therapies that we have been speaking about. Additionally, if the blood pressure is the problem, then that has to be looked into, or any other conditions where a multisystemic involvement has happened. The aim is to keep the sugars within normal level, the blood pressure also within normal levels, and all the functions of the liver, kidneys, and systemically, like the eyes, have to be in a normal functioning range. The ultimate is to then work out a time limit when to deliver these babies. So, depending on each part of the examination and the scan findings, where the baby will also be looked into details, especially in the scan, we have to look for polyhydramnios, which is extra water, any evidence of any IUGR, which is the fetal growth restriction, which is also which comes with diabetes, or extra growth of the baby. The baby grows more, which is macrosomia. So, either of the features, along with the maternal complications that we've been speaking about, will tell us as to when to admit the patient and then think about delivering the baby. So, if everything goes okay, if the sugars are within normal limits, the pregnancy can be continued on till 39 weeks, obviously with the counseling to the patient that the patient needs to maintain the sugar monitoring chart, has to come for regular follow-ups, which is every 2 weekly till 28 weeks, and then weekly till 32 weeks. Then this depends on how good the control is. We can vary these follow-ups, but certainly 2 weekly at the most we should be doing, if not weekly. And then if the sugar levels are poorly maintained, or the parameters of the kidneys or livers is rising, then these women need to be admitted for a multidisciplinary management of the patient, and we can then start thinking of delivering these ladies at 37 weeks. If all is well, which means there's no obstetric indication of a cesarean section, these women can have an induction of labor at 37 weeks. There is no real necessity for a cesarean section if there is no obstetric indication for a cesarean section.
Dr. Poonam, we have discussed so much about the management of gestational diabetes, but we have also been talking about women who have very high blood sugars or women who have overt diabetes. These women are to be referred to the specialist right from the time of their diagnosis. So, what additional testing and what are the additional steps in management in women who have overt diabetes?
So, the women who have overt diabetes, where the sugar levels are more than 200 milligram per deciliter, are at much of a higher risk from the maternal perspective as well as the fetal perspective. So, the specialist looks into the entire pregnancy and guides the women accordingly. So, the most important thing is to make sure that the folic acid 5 milligrams has been started, and then a plan of management has to be made as to when the different scans have to be done. So, the first level scan, which is after the viability scan, is the most important one, which is also called as the NT scan, where we do the NT of the baby, which is the nuchal translucency of the baby, along with certain blood tests to ascertain the risks for aneuploidies. Following the nuchal translucency scan, at 16 to 18 weeks, there is a very important scan where the entire structures of the baby, including the heart, is looked into in details. This is called as a level 2 or the TIFA scan. This is further followed by a cardiac scan of fetal echo at about 22 weeks, and similarly we do an anomaly scan at the same time. And this would be important also for the growth of the baby from the 16-week scan that we've had. Obviously, with the scans, if everything is okay, the monitoring of the baby and the mother has to be documented on the charts that has been provided, and a referral system needs to be made with the endocrinologist, because such a woman has to be looked after in a multidisciplinary team. So when the patient comes in, not just the diabetes bit, but also the other complication that can coexist with the diabetes, like the hypertension, the cardiac, the renal problems, and the fundal issues that can come with diabetes needs to be looked into, and the management guided accordingly. The sugar levels have to be tested, and if beyond a certain limit, despite starting the MNT, the exercise and the metformin, the endocrinologist would then start these women into insulin, for which the women would be counseled for hypoglycemia as well.
So, how common is hypoglycemia after insulin, and what are the signs and symptoms, so that we can counsel the patients accordingly and these cases can be picked up early? Because from what I understand, hypoglycemia should be very dangerous for both for the mother and the fetus.
Yes, hypoglycemia is certainly very, very dangerous for both women and the baby, the fetus, which is diagnosed when the sugar levels become less than 70 milligrams per deciliter. Now, sometimes the women can present with tremors, feeling of uneasiness, shaky, feeling of fatigue, and these symptoms have to be told to the patient, because only when these symptoms are told will the recognition happen and straight away the blood test can be done. There can be severe symptoms of hypoglycemia, which can be in the form of confusion, very severe form of irritability, for which the management has to be started straight away after the sugars are done and it has been documented that it is less than 70 milligrams per deciliter. The management can be just in the form of taking 2 to 3 tablespoons of sugar with water and instantly drinking it. And any of these episodes which happen more than once in a day needs to be referred to the specialist at the earliest possible.
Now, Dr. Poonam, we have talked so much about antenatal management of gestational diabetes, overt diabetes, how to manage these patients, their diagnosis, and when and how to deliver them. But somehow I feel that in our country, the postpartum care of such women is oftentimes neglected. Could you also highlight what postpartum care or testing do women diagnosed as gestational diabetes need in the postpartum period?
Right. So after the baby is delivered and these women are sent back to their homes, it is important that they are counseled for the postpartum care that can happen or needs to be done with after the diabetes has been diagnosed in pregnancy. Not just the women, but the entire family should be aware of symptoms associated with either hypoglycemia or extra sugar that is there in the mother. Now, how to do is that regular monitoring is needed as it's been happening, but majority women wouldn't need any monitoring because the sugar levels comes down just after the delivery happens, and also because the woman is breastfeeding. 6 weeks after, glucose tolerance test needs to be done, the OGTT, which can also reflect whether the woman has come back to the normal levels or she needs more monitoring, because as mentioned before, these are the women who needs to be monitored quite regularly, in fact every year throughout their life, because of the increased risk of diabetes in their lives. So if the sugar levels or the fasting becomes more than 140, or the post 2 hours becomes more than 200, then these women would continue to need the specialist care and advice until the sugars are back to normal. We must not forget about contraception, and we must not forget about the follow-ups, which should be a little more often as compared to the women who have no problems.
Thank you so much, Dr. Poonam, for highlighting the diagnosis and management of gestational diabetes and overt diabetes in pregnancy. So today we have learned that gestational diabetes is extremely prevalent in our country. And like any other high-risk condition, for its proper diagnosis and management, a thorough history and examination are a must. All pregnant women, irrespective of the period of gestation when they present to us, should undergo the OGTT using 75-gram glucose. On the basis of this test, they should be classified as normal, or women with GDM, or women with overt diabetes, and then managed as we have discussed right now. By following these simple steps of diagnosis and management, we can bring down the morbidity and mortality caused by gestational diabetes to a large extent. To know more about the management of gestational diabetes by different levels of healthcare workers, you can refer to our protocols. Thank you.
That brings us to the end of Film 2 on the identification, treatment and management of diabetes in pregnancy. Remember to refer to the high-risk pregnancy management protocol for more details.